Welcome to the Explainer. When most of us hear the phrase high blood pressure, we instantly picture that standard Velcro cuff getting wrapped around our arm at the doctor's office, right? But what if I told you there's a hidden, incredibly destructive form of high blood pressure that your regular arm cuff literally cannot detect? It's a condition that secretly targets the vital connection between your heart and your lungs. Today, we're unpacking a true medical mystery, a complex and deeply impactful condition known as pulmonary arterial hypertension. Okay, let's dive right into this. To really understand how this hidden condition works, we're going to follow a clear roadmap. First, we'll cover the hidden high blood pressure. Second, the causes and culprits. Third, symptoms and heart strain. Fourth, we'll navigate what's called a diagnosis of exclusion. And finally, we'll wrap up with treatments and management. So, starting off with Section 1, the hidden high blood pressure. Let's define exactly what it is we are dealing with here. At its core, pulmonary arterial hypertension, or PAH, is a rare disorder that is completely distinct from your standard everyday high blood pressure. In PAH, the high pressure is located specifically and exclusively in the pulmonary arteries. Now, these are the crucial vessels responsible for carrying blood away from the right side of your heart and straight into your lungs to get oxygenated. And here's a rather surprising demographic fact about this. PAH actually most commonly occurs in middle-aged biological females. It's a highly targeted condition. But to understand why PH is so dangerous, we have to look at the mechanics of it. We really have to ask ourselves, what actually happens when the vital pipes connecting the heart to the lungs suddenly become too narrow to do their job? The absolute easiest way to visualize this disease is through the pipes and pump problem. Think of your pulmonary arteries as a complex system of pipes, and the right ventricle of your heart as the pump that's responsible for pushing fluid through them. In a healthy body, those pipes are wide, they're relaxed. But in PH, we see severe vasoconstriction. Basically, the walls of the blood vessels physically tighten up and thicken. Suddenly, the pipes are incredibly narrow, and you can imagine this creates massive resistance. So the pump, your right ventricle, now has to work overtime, pushing with incredible force just to get the exact same amount of blood through to your lungs. And this mechanical problem, it quickly turns into a biological catastrophe. It's a rapid, cascading chain reaction. First, you have that vasoconstriction and wall thickening. That instantly shoots up the resistance to blood flow. Because of all that new resistance, the right ventricle gets severely overloaded. Over time, just like any muscle lifting weights that are way too heavy, the right side of the heart physically enlarges from all the strain. But our hearts aren't meant to function that way. Eventually, that enlargement progresses to a devastating endpoint called cor pulmonale. That is full-blown right-sided heart failure. The blood quite literally backs up into the right side of the heart because it just can't push through the lungs. Which brings us to Section 2, causes and culprits. Now that we understand the mechanics, we have to play medical detective. What causes these arteries to thicken in the first place? Well, the variety of culprits is honestly staggering. The most common cause is actually categorized as idiopathic, which is medical speak for we have absolutely no idea what triggers it. But as for the known causes, it could be a genetic mutation in the BMPR2 gene causing smooth muscle cells to just rapidly reproduce. It could be a connective tissue disorder like scleroderma that damages the vessels and releases constrictors. Incredibly, it can even be triggered by other diseases like congenital heart issues or stimulant toxins like cocaine, or get this, schistosomiasis, which is a parasitic flatworm infection. But here is the absolutely crucial takeaway. Whether the trigger is a genetic mutation or a parasitic flatworm, the anatomical result is exactly the same. The pipes constrict and the pump begins to fail. Let's move on to Section 3, symptoms and heart strain. So how does this actually manifest in a patient's body? There is a really sharp, frankly terrifying contrast between the early symptoms and the late-stage complications. Early on, the signs are incredibly vague. Difficulty breathing, a little fatigue, weakness, dizziness, maybe fainting, which doctors call syncope. I mean, these are symptoms you could pin on 100 different things, from mild asthma to just being a little out of shape. But look at the late stage. This is what happens when right-sided heart failure actually sets in. Because the blood is backing up, fluid starts pooling everywhere. You get edema, which is severe swelling in the face and legs. You get ascites, where fluid collects in the abdomen. The liver enlarges. And amazingly, patients can even experience hoarseness. Not from a throat infection, but because their pulmonary artery has enlarged so much, it's physically compressing a nerve right inside their chest. Ultimately, they can develop cyanosis, taking on a bluish tint because their blood oxygen levels are just critically low. Next up, Section 4, a diagnosis of exclusion. Because those early symptoms are just so vague, catching PAH is one of the most frustrating investigations in all of medicine. PAH is what doctors call a diagnosis of exclusion, meaning you essentially have to prove what the disease is by exhaustively proving what it isn't. It's a three-step maze. Step 1, suspect it. A patient comes in with breathing issues and a chest x-ray or an echocardiogram hints at enlarged arteries or strained right ventricle. Then comes Step 2, the grueling exclusion phase. The doctor has to rule out chronic lung disease using a spirometry test. They have to rule out blood clots using a VQ scan. They run autoantibody tests to rule out autoimmune diseases. You literally have to eliminate every other suspect first. Finally, Step 3, confirmation. The only way to truly 100% confirm PAH is a right heart catheterization. That's where they run a line directly into the heart to literally measure the physical pressure inside the blood vessels of the lungs. And that brings us to Section 5, treatments and management. Okay, once we've successfully navigated that diagnostic maze, how do we mount a counterattack? The medical strategy here is divided into two very distinct camps: supportive therapy and specific therapy. Supportive therapies are all about managing the fallout of that failing heart. If fluid is backing up and causing swelling, we use diuretics to flush it out. If oxygen is low, we give supplemental oxygen. We also use anticoagulants like warfarin to prevent blood clots from forming in those narrow, high-pressure vessels. But supportive care doesn't stop the disease itself. To do that, we need specific therapies, primarily vasodilators. These are the heavy-duty medications designed to directly attack the mechanism of the disease. They literally force those constricted blood vessels to dilate and open back up, relieving the crushing pressure on the pump. And medical science attacks those constricted vessels through three distinct biological pathways. I like to call it the rule of three. First, there's the prostacyclin pathway, using drugs like epoprostenol and iloprost. Second, the endothelin pathway, which is targeted by medications ending in santan, like bosentan or ambrisentan. And third, we have the nitric oxide pathway, utilizing drugs like sildenafil and riociguat. These three pathways represent our absolute best effort to chemically prop those pipes open and give that struggling right ventricle a fighting chance. But even with these incredible medications, we have to acknowledge that PAH is a relentless disease. For individuals with advanced, irreversible cases, where the blood vessels are permanently thickened and the medications simply no longer work to relieve the pressure, there's really only one final option left. The patient will require a double lung transplantation to entirely replace that damaged network of pipes. So, to wrap our heads around everything we've covered, the crucial takeaway is perfectly captured here. PAH is a diagnosis of exclusion. It's a hidden, underlying increase in resistance. It is the ultimate mechanical battle between a struggling pump and a continually narrowing vessel. It really requires us to look past the standard signs of high blood pressure and investigate this vital, fragile pathway sitting right in the center of our chests. Which leaves us with a pretty fascinating thought. We now know that genetic mutations, like with the BMPR2 gene, cause those smooth muscle cells to multiply and clog the arteries. So, as modern science and genetics continue to advance at this breakneck pace, you really have to wonder, how close are we to a true cure? How close are we to perfectly targeting those genes and stopping this hidden high blood pressure before the right ventricle ever even begins to strain? It's a very promising horizon for a deeply complex medical mystery. Thanks so much for joining me on this explainer today, and keep asking the right questions.